Hi, everybody, and welcome to Greeley's Healthcare Podcast. We're recording this discussion on what is today, the 16th of April, 2020. And I'm Bud Pate. I'm the Vice President for Content at the Greeley Company, and I'm gonna be having a conversation with my friend and colleague Lisa Eddy, who's an advisory consultant over most of our compliance field operations at the present time. Morning, Lisa.
Thank you, Bud. Today we're going to be talking about what the hospitals and healthcare organizations can expect. There's just so many questions about what the regulatory landscape is going to look like post-pandemic. And Bud and I were having a conversation, and I had several questions for him, and we were kind of having a dialogue back and forth and thought, gee, some of this information, especially with Bud's expertise as a prior director over the Los Angeles, California Department of Public Health, and his intimate knowledge of CMS conditions of participation, what hospitals could be expecting post something like this. So one of the things I want to talk about to start, Bud, I know that we've had discussions and we put out podcasts and so forth and blogs about waivers, and I've had several questions asked of clients of me about waivers, and I know that you talk about waivers, but what I found was interesting is some waivers are being denied. Can you talk a little bit about that and what that would look like during a resurvey or a survey post-pandemic if hospitals don't get those things corrected?
Yeah, let's just have a conversation. It's a broad topic and there's a lot to cover in there. First of all, I just want to be clear about my background. I'm 30 years plus ago, I left the government. I was working for the County of Los Angeles, and in that position, I was over all of the licensing and certification activities on behalf of the state of California under contract for acute care, essentially, within Los Angeles County, so hospitals and things like that. So I was the state agency representative for hospital type surveys in Los Angeles County. So just to be clarify, about the relatively narrow scope of my background. But so anyway, Lisa, yeah, as we were talking about, some people are confused about waivers. Some people are asking about waivers and they're getting waivers rejected, and what does the waiver cover? And there's a lot of material out there on the web about 1135 waivers, but there's all other kinds of waivers that are available as well. So we just wanted to, try and get that clarified. So yeah, so one of the things that was interesting is that we've heard from some of our consultants that their clients are indicating that their waivers are being rejected. And this is mostly in the physical environment area. So I wanted to say, explore that a little bit as to why they might be rejected and how to get them approved if, of course, they're a valid request. Have you heard anything about that, Lisa, from your contacts in the field?
From my contacts, I've just had questions about implementation of the blanket waivers, but not that there's been any denial of waivers, specific 1135 specific waivers that they've requested. I have had questions about, would this scenario require a blanket waiver? Are we stepping over the line with this scenario? So a good example is those healthcare organizations that are hospitals that are setting up outside of their ED, that are setting up locations for COVID screening and are testing for patients, then we've stepped outside and we would have to actually implement the waiver. If you just set up an alternative site for your own employee testing, you want to test your own employees, then you have not breached any sort of an EMTALA issue, and you're not in needing to implement a waiver. But I've just had questions really, Bud, about is this waiver, ready? Do we have to, implement a waiver for this? And one of the things too that I've had questions about has been, well, if we implement this blanket waiver, and I would just appreciate you kind of expanding on this discussion a little bit. If we implement a CMS blanket waiver for X, do we have to notify the state? Well, no, you don't have to notify the state unless the state, and you correct me if I'm wrong, unless the state has a specific regulation that would need to have a notification and then request for the exception that the CMS waiver would allow. You want to talk about that a little bit, because I think people get confused about that.
Right, there we go. Yeah, thanks, Lisa. It is a confusing area, I mean, I have to say. And I'm old. I've been around for a long time. It takes me a while to wrap my arms around it. But there are many, many different kinds of waivers and variances that are available. 1135 is just one flavor of those. And even within 1135 waivers, there's two basic kinds. There's blanket waiver, and then there's a waiver that's requested on a case-by-case basis, either for a specific provider under their CCN or a group of providers. So let's talk about blanket waivers. So blanket waivers are just take effect. They're automatic. You don't really have to do anything other than understand what the waiver covers and what it doesn't cover. The waiver goes back to March the 1st, 2020, and is good through the duration of the pandemic. And we'll talk a little bit about what we mean by the duration of the pandemic, because I think that's an interesting topic. It's a little bit of a moving target, and the pandemic may be over in one area and not over in another area. So, but anyway, that is a blanket waiver, and it just automatically applies. Then there's the facility specific, and of course, as you were talking about in your question, really no contact with the state is necessary for that 1135 waiver. Of course, if the state has a requirement that also has to be waived, then that would be a separate matter. The 1135 waiver does not automatically waive state requirements. It's only for CMS requirements. So the state dynamic would have to be handled differently. So on the blanket waivers, the first flavor, the one that we're most familiar with, you don't have to do anything. You just need to know when the waiver is over and then try and recoup to get back into compliance, generally within 60 days after the conclusion of the pandemic. So the example you talked about was this blanket waiver for EMTALA. And I know we have had a question, we're setting up a testing site, a separate testing site for our employees when they come to work, so that we can test them to make sure that they don't have an active COVID-19 infection. So would that be covered by EMTALA? Not at all. So EMTALA does not address employee health or employee screening. That could be done anywhere. And with no EMTALA obligations. If it's patients, on the other hand, then normally EMTALA would require that you first do a screening and then refer them to an off-campus location. Remember, EMTALA does allow you, without any waiver necessary, to redirect people to different on-campus locations. But as far as going off campus, having to get in the car and drive, essentially, is what we mean by off campus. If you're you can't really, under EMTALA, medically screen a patient who comes to your emergency department to those off campus locations without first doing a medical screening. Well, that requirement has been waived beginning March the 1st. So you can now direct them to off-campus locations. But let me just address one other thing here. People are confused about the starting date. These blanket waivers weren't actually issued or communicated before March 30th, and yet I'm saying March 1. Why is that? Well, it's because they made them retroactive. So there's confusion, and there's also dates around the middle of March, but when the blanket waivers came out, they post-dated them to March the 1st. Now, as far as facility-specific waivers, that is one where you do have to notify the state. There's a process. It's a little bit of a complicated. I mean, it's easy, but it's complicated. But we have been hearing that some people have had their facility-specific waivers denied, and we suspect, and our current experience is the reason it's denied is that they really weren't well crafted and they didn't answer the things that needed to be put into the 1135 waiver. But generally speaking, CMS is going to waive things that make sense. But in order for it to make sense, there are some things you have to put into the waiver request that really will help. The first thing is that you've contacted the authority with jurisdiction for physical environment, and that might be usually is the fire department, local fire department, and they need to support that requested alteration. It could be testing and maintenance or something else. If they're not in support, then the 1135 waiver wouldn't make any difference anyway, because you'd be out of compliance with the local requirements, which is a fundamental CMS requirement. And so they're not waiving that. CMS is not waiving that. So if the authority with jurisdiction doesn't sign off of it, and if you don't indicate that in the waiver request itself, it's likely that your 1135 waiver request would be denied. There are other reasons as well. I mean, that's what we do though for a living, day in and day out, is get these sorts of things approved. So we have a lot of experience in that. I'm sorry for rambling on. I don't know, is that sort of answering your question, or is it raising more?
No, well, yes and no. So let me just ask you this question, because I've had a number of clients contact us and say, hey, what are your recommendations for all, and I'm going to be specific and hope that helps answers questions about things that are very specific that don't appear to have a blanket waiver. So I've had clients call and talk to me about, I have to go to an alternative use of PPE plan, and we advise them to do a good solid risk assessment and go to the CDC and use all the recommended recognized national recommending bodies for their guidance. But for example, we know that the conditions of participation don't say specifically in the actual law language that you must use PPE. What they do say is that, you know, you have to follow best practice. There has to be rules and policies and procedures related to infection control oversight. And in the discussion in the interpretive guidelines, it talks about the proper use of personal protective equipment. So there's not a blanket waiver that waives that, other than there is the discussion of use of PPE during sterile compounding. There's a provision that gives you some flexibility there. But so let's say, but in your advice to an organization, if we were to go ahead, as many organizations have had to do, and alter the way they would normally use PPE, and they've done a risk assessment, so what would your advice be to them in terms of CMS?
CMS has already acknowledged and is following the CDC guidelines for the use of PPE. And what those guidelines indicate, so really it's not, there is no need for an individual waiver for the use of PPE. It's just a conservation of masks and gowns and things like that in times of short supply that need to be in compliance with CDC guidelines. So in a number of different communications, CMS has and Joint Commission have deferred to the CDC into when and how you would do that. And there's two main ways to do it. One is to reuse the PPE, but more common is the extension of the use of PPE. So reuse of PPE is that you take it off, remove it, the next day you come back in and put it on again, versus the extension of the use is that you just don't take it off. You don't doff it as frequently. You continue to use it as time goes on.
What I'm actually getting at here, Bud, is just for our listeners, I think everybody understands the reuse and the extension of PPE. What the questions that keep coming up is, I think there's been so much discussion back and forth from CMS. We have some clients that think they have to expressly ask for a waiver when they use alternative PPE, meaning they extend the use of PPE. And to my knowledge, they clearly don't have to ask for a waiver because there's been all of this communication from CMS and, as you mentioned, Joint Commission to sort of give you, as long as you follow the recommendations of CDC, you kind of get a pass on that, and there's nothing special, quote unquote, that has to be done.
Yeah, and I think that's the specific answer to the issue of PPE, but I think it raises an underlying question, is that when do you need a waiver at all? Well, if something, you only need a waiver when something is specifically required, and as you suggested in your conversation, there is no specific guidance on the use of PPE other than you follow nationally recognized infection control practices, and that's sort of the general rule. And as long as you're, unless you're doing something that's completely contrary to CDC recommendations, then you would comply with that underlying CMS regulation. So I think that does raise the issue of, gee, when am I violating the regulation? Am not violating the regulation? And that's a question that many of our clients have, and that's where we come in. Well, we know what the regulations require and what they don't. But if you're not violating the regulation, like in this case, then no waivers necessary at all, in neither blanket waiver nor individual facility waiver.
So, but if we can talk about, and I'm very interested in what your thoughts are about when the government relaxes some of the, or when surveyors are ready to get back in the field, frankly. What do you anticipate a survey is going to look like?
Yeah, I think, even before we start talking about surveys, what about the end of the waiver period? And I mean, and so the end of the waiver period will probably happen around the same time as surveys recommence. And it's a little bit of a moving target, and when surveyors come out, there are probably going to be some different interpretations. But right now, the most consistent interpretation that we've found, articulated by both Joint Commission and CMS representative, is that the end of the waiver period is going to be either the end of the national emergency, or the end of the state emergency, or the end of the local emergency, whichever is the latest. Now, I've heard alternate interpretations of that, saying no, it's only the end of the national emergency, which would apply to the 1135 waivers. So we give that advice with a little bit of an asterisk, but that's the current April 16th, 2020 interpretation of when the end of that waiver period would happen. Certainly that's when the surveys, though, would start happening again, as the surveyors from Joint Commission, for sure, are not going to be coming in until that local emergency or the is over, even if the national emergency has been taken down. So we know that the surveyors won't start coming in. And it's at that point that they're going to start looking retrospectively. However, there's a general idea that you'll have 60 days to be cleaning up any delinquent privileging or delinquent testing of radiological health equipment, that sort of thing that has been waived. You'll have 60 days to catch up with those things. So when the surveyors do come back in, ultimately, and we can talk about that a little bit as to what they're, once the pandemic is over, even locally, what is it? What's, how soon do you think you'll be surveyed, and what's the priority? We talk about that. But ultimately, when they do come there, they're going to look for that 60-day catch-up period. So our advice to clients is have as few things to catch up on as possible. Continue to process those things that you can. Sometimes you just can't do something, for example, radiological equipment, you can't do it because you need a vendor and the vendor's just not willing to come out during this crisis. But if they are willing to come out, have them come out and do the inspection and testing. Your community may not be impacted by a large volume of hospital patients, or for some other reason, you may be able to do that testing, or you may be able to reprocess their credentials because you're still functioning. Don't hesitate to do that. Stay on top of it, because believe me, 60 days is not a long time, especially when it's on top of everything else that's otherwise due in that 60-day period. So you're going to be really doing double work for anything that you've deferred until after the survey. I mean, excuse me, after the, not survey, but things that you've deferred until after the end of the waiver period.
So, in one of the things that I had conversations this week with several members of one of the CMS regional offices, and we were talking about when things get up and running, and they were pretty clear for their regional office, they won't be back in to facilities until it's safe for the surveyors to do so, unless there's an immediate jeopardy or some sort of a complaint that would rise to such a high level of concern that they felt the patient population was unsafe. So what I'd like to just kick around with you a little bit, Bud, is the prioritization of when the surveyors are ready to get back in to the field, both the Joint Commission surveyors, the state agency, the CMS, and we do know the state agency has a different agenda than CMS, and they have different things that they're going to be focusing on and looking at during the pandemic. But if you want to just talk a little bit about what you think the prioritization would be, that would be helpful.
Yeah, I think when the surveys resume, let's look at it in a couple of different frames, because there's state inspections, on behalf of CMS, and then there's accreditation surveys, and those are three totally separate things. The state inspections and the state inspections on behalf of CMS look a lot like the same thing to the client, but they're really very different things. So let's first talk about state inspections just on behalf of the state. And different state departments have a different role. It's a little bit different in Texas than it is in Florida, as it is in New York, as it is in California. So, but the role of that state agency that licenses or governs hospitals is often a part of the state or the community's disaster plan. So it's quite possible that you have licensing representatives coming out and visiting you as part of an essential service, just like you used to give feedback to the state as far as how many beds there are, is this meeting some sort of minimal standard as far as surge capacity and surge staffing. So different state agencies may be doing that across the country. Now, when CMS wants the state to represent them, they will authorize the state to go in on behalf of CMS. So that's now the second bucket of survey. And those surveys, like you said, are controlled really at the regional office level and the local level by the regional office or the consortia of regional offices. And those surveys will start, as you suggested, with really serious complaints, things that really sound very dangerous to the person who's received that complaint. And by the way, when I say complaint, I'm also including anything that's been self-reported to CMS by either by the state or by the hospital itself. So anything that's reported to CMS that they think is dangerous, they're not going to have any unnecessary delays, and they'll need to work those things off as first priority. Second priority are going to be outstanding enforcement actions. So if there are unresolved deficiency statements out there, so they've been cited for something and they haven't yet, the state has not yet cleared them, they will need to clear those pending deficiency statements. Now, there's two ways to do it. They can call them and do a virtual clearing because they'll have a backlog of these things too. All of these 2567s that there's no follow-up on, or and sometimes not even a plan of correction. So they'll have to work that off, just like you're working off your delinquent inspection maintenance. The survey agency is going to have to work off this backlog of statements of deficiencies that are not resolved. And then after that, then they're going to be going in on things like SIA revisit inspections and things like that. And the distinction there is there's really no pending deficiencies. It's just that they have to do another survey to clear out SIAs. One thing I forgot to mention, though, of course, are initial certifications. Those are actually going to move right to the top of the survey list because CMS wants to / needs to assure the supply of providers is sufficient to meet the demand right now. So that is also going to be very high on the priority list. And I think it's going to be a long time after the close of the survey, a long time before we get back into anything that's quote routine, either by the state alone or by the state on behalf of CMS. So before I get into accreditation surveys, which is slightly different, I just want to say, does that make sense, Lisa? Or am I being too bureaucratic? I tend to get a little bureaucratic. Sorry about that.
No, I don't think you're being bureaucratic. You've parsed out what the priority is, and you said until we get to the end of survey. I think you meant until we get to the end of the pandemic, and more on the other side of that. But no, I did ask you for the prioritization. I have another topic I want you to cover, but I know you want to talk about the accreditation piece.
Yeah, let's talk about accreditation first. So on accreditation survey, it's very similar to what CMS priorities are going to be. But as you know, the vast majority of CMS surveys of hospitals are done by accrediting organizations, most frequently the Joint Commission. And the Joint Commission is going to start, just like CMS, with initial accreditations, and they have a slight backlog of those. And then they're going to continue on with unresolved enforcement activities and making sure the evidence of standards compliance is in. There's a follow-up survey for a conditional level deficiencies or preliminary denials of accreditation. Now, as we think about that, though, they're much more likely to restart in home care or ambulatory care, the non-hospital setting, because those are going to be less impacted by the pandemic than the hospital environment. So they're probably going to start with some of those other accrediting programs before they get into the hospital environment. So it's similar to the CMS restart, but at least from the Joint Commission standpoint, they'll be prioritizing, like I said, initial accreditations and resolving adverse actions like condition level findings or preliminary denials of accreditation. And then they'll start working off the backlog of the triennial due surveys after that. And it's going to take them a while, significant amount of time to catch up.
Right. I anticipate that as well. The question I was going to ask you is, and here's something that one of my clients said to me, and I had another client that sort of said the same thing, which was, gee, with all that's going on, we've had to furlough because we don't have the elective surgeries, we don't have the admissions, we don't have the patients in our clinics or the patients coming to the ED and so forth. We've had to furlough a lot of our staff. And so some things just aren't getting done, and they don't really fall within a specific waiver, 1135 waiver, and they're not under a blanket waiver. But don't you think, Lisa, that the surveyors will be understanding during this coronavirus time? And I said to them, the reason that CMS came out with the discussion on applying for waivers and the blanket waivers that they're allowing is because they're trying to give you an avenue to work around the things that you can't comply with in a structured fashion. So no, I think that you will be surveyed to the letter of the requirements within the framework that they've given you. Meaning, if you've stepped over the line in compliance because you didn't have the staff, or and legitimately, if you furlough somebody and you have to because you want to keep the doors open, and you have to furlough, let's say your medical staff, some of your medical staff professionals, and you can't get your credentialing done or whatever it happens to be, you still have to abide by the regulations that are out there. And there's been some allowance for that particular component, credentialing and privileging. But if you stepped over the line and you have not requested a specific waiver, or you're availing yourself of the blanket waivers, but you go beyond what they're allowing or whatever, there's going to be issues when you actually are surveyed. So what's your opinion on that? That's my take.
Yeah, I think the Joint Commission is going to, and any surveyor is going to be understanding of things that happen during the pandemic and when your disaster plan was in place, including the lack of, activity that caused a furlough. However, they're going to be understanding about that, and depending on the surveyor, they may sort of, not focus on that pandemic period. But the reality is, if you don't have a waiver that you've actually gotten approved, or it's not something covered by a blanket waiver, you're out of compliance with the regulation, and it's the surveyor's job to actually reflect that in the report. Now, what's the impact of that? Is it likely that you had a condition level finding because there was a period of 5 weeks where you were not out of compliance, but you came back into compliance subsequently? Now, probably not. That's probably not going to be serious. But if you went out of compliance, there was no waiver, and you still haven't recovered, and people have come in, then you're looking at a potentially serious finding. So our advice is always, we have a lot of people working right now to get these waivers in place. The first thing we do is we say, well, first of all, is a waiver really necessary? And if, in other words, is the practice you're talking about, does it really violate any regulation? And we look at the local and state regulations, as well as CMS and Joint Commission, or whoever your accreditor is. We look at all that set of regulations and say, is there anything that this practice violates? And over half of the time, we say, you know what? You're not, you can just go ahead and do this. There's nothing that you're violating. But assuming you're violating something, then we check, is there a blanket waiver that would apply? And we have to check at the state level, because 1135 waivers don't necessarily cover state or local requirements. And so we look at those things. And again, if it's covered by a blanket waiver, both at the accreditation, the federal, the state, and the local level, again, you don't have to do anything. But if you are in violation, then we help you get a waiver approved. And that's sort of a nuanced skill that most hospitals don't have, is to work through the bureaucracy to get these waivers approved. It sounds like it should be an easy task. It's really not, but it's one that we do all the time.
Yeah, thanks, Bud. The issue that I try to tell clients is, I think when there's a survey after this is all said and done and surveyors are back in the field, that the surveyors will have a level of understanding of the situation that hospitals are with, and there will be some consideration of that, but they're not just going to give you a free pass if you stepped over the line and didn't avail yourself of the 1135 waiver process, or something else occurred and you didn't really take care of it. As you said, I don't think that they're going to slam down a condition necessarily, but I think that they will. I mean, they're obligated to, if you're out of compliance, they're obligated to identify that. So like you said, I think it's going to, and this is what I tell clients, it's very surveyor dependent. I think there'll be a higher level of understanding than there has been for this time period, and probably for a little bit of catch-up period. But that leads me to another question. But what what do we do if we have a hospital, and this is very specific to hospitals and SIAs, or you have a hospital that maybe is in adverse action and they're holding off on coming in, and then you have a term date, but they've blown past that because of the pandemic. So if you have any of those, the 60-day time period after the pandemic is officially called, what does that look like in that gap period where you have, maybe you've already reached your term, but you've got 60 days, or let's say that your SIA term date is even before the 60-day time period that the pandemic is called in, and you've got 60 days for whatever it happens to be that you've waived. Can you talk about that a little bit?
Yeah, sure. I mean, I think what you're describing here, just to rephrase it, just to make sure I'm responding to the right thing. You've got a sword over your neck, and they're going to either terminate you from, they're going to deny your accreditation, they're going to terminate you from Medicare, or you've been in a systems improvement agreement and you're ready to get that resolved. So this is a pending enforcement action that we were expecting in March, but now it's already April, it's already May, and that action just hasn't taken place yet. Well, remember that the government has all the latitude in the world to extend that, to not drop the hammer on you. And so they may formally extend the duration of a termination action or a preliminary denial of accreditation. They may do that, but they don't have to. They can just put it off. And when they do come in, it's more important than ever to do what we talk. You don't want to be caught doing something that's non-compliant. Now, waivers are going to apply to people who are under termination action or an SIA. So a waiver is a waiver if it's a blanket waiver, and people who are under threat of termination or loss of accreditation or a system improvement agreement, they can request a waiver just like anybody else. But it really is important that they go ahead and request that waiver or make sure that their practice is covered by the waiver, because when the government does come back out, they will be including that pandemic period as part of what they're looking at to sign off on your compliance. They'll give more emphasis, sure, on the latter part of that period, the recovery period, but they'll also look at the time during the pandemic. And remember, a lot of these termination actions, SIAs and others, are all about readiness for disaster and infection control. So it's perfectly within the purview of the accreditation and regulatory agencies to evaluate how well you implemented infection control practices during this pandemic as part of a legitimate survey process. Having said that, I don't think anybody is going to be anxious to terminate suppliers during this time. So there may be, opportunities for understanding and extensions, and gee, it wasn't a perfect survey, so we're going to come back later. But boy, if I had a sword over my neck, I would make sure that I got that removed so that there was no more pending hassle, because I've got enough on my plate. I don't need the bureaucratic worries about my accreditation status or my certification status. I would want to resolve those first time out of the box. And obviously, Lisa, you know about that as much as anybody else, because that's what you do day in and day out, is get people out from under those problems.
So, well, another thing, but I know we're running out of time here, but just to kind of conclude this in some way, I've had clients ask me, Lisa, what do I need to have ready? What do I need to do? Do I need to make a book? Do I need to do an evidence book? Regular hospitals that are not under threat of termination or in an SIA, that just clients saying, we've done all these things. We've got a command center. We've got this, we've that. We're implementing the blanket waiver on X and Y and whatever, or we're using alternative PPE or whatever it happens to be. Do I need to do anything special? And my response to them is, you need to do exactly what you've been doing in the normal course of business, which is if you've done a risk assessment to use, extend your PPE, alternative use of PPE, whatever it happens to be, what you need to have your risk assessment ready and available for the surveyor. And you're obviously, if you're extending the use of PPE or whatever it happens to be, and you also have infection control surveillance and you have data on that. There is a blanket waiver for some components of your QAPI program, but it does not absolve you from continuing to monitor quality and safety throughout the institution. And so you'd have to show evidence of that. If you completed a waiver, you have to show the rationale behind it. So in other words, you need to continue business as usual. You don't have to create some special look what I've done book, but as you go about your business, and if you've deviated for any reason, you need to be able to show the rationale for the deviation, that you've done a good thorough look at what the pros and cons, the downstream impact, unintended consequences, and so forth of the deviation. If you needed to get a waiver, that you've got that on hand. And then you need to be able to show the compliance with what it is that you're asking or that you're doing, and that all of that has been appropriately reviewed by oversight bodies throughout your institution, whatever that infection control committee or governing body or leadership, whatever it happens to be. And you would just continue to document that and have evidence of that as you normally would. You don't have to necessarily create something different. Now I know, but you and I've worked with our organizations. They have very good command center meeting minutes and records of what they're doing, and their deployment of their emergency operations plan, emergency management. And we've seen that. That's something that we recommend, obviously, as you're going about deploying your emergency management, your emergency operations activities, that you keep a record of what you're doing, and we can find a trail of that. A surveyor is going to look for that. But I don't recommend that they do anything specific or different. Well, how about you, Bud?
Yeah, I think they just keep doing the right thing and continuing as much of the normal process as possible, realizing that that's not going to be totally possible. That there are some things that will inevitably fall through the cracks during the pandemic. However, once it's over, now's the time to look back and think about, well, what is going to be the focus? Now, this is, like you say, Lisa, these are not people who are under termination action, but just everybody else who's worrying day to day about compliance. If you were a survey, what would you be looking at? Well, you're going to be looking at your emergency management surge planning, staffing planning, how you staffed, how you went back and you gave temporary privileges or disaster privileges to practitioners, or you approve volunteers to come in and work, or maybe licensed in another state. They're going to be looking at your infection control program. And so that's what people are going to be most interested in, because they're preparing for the next pandemic or the next wave of this pandemic. And so you don't have to do anything different.
Yeah.
But you just need to be able to explain and demonstrate what it is you had done in the past and how that informed your preparations for the next time this kind of thing happens.
One of the things, Bud, earlier this week, in talking with one of the regional offices, we sort of talked about this a little bit in terms of resurvey and so forth. And of course, they can give absolutely no data. They don't know when things are going to be lifted. But the big focus was when we come back, we're looking to see that patients were kept safe. That was the big focus. And that, in any survey, that's the thing that's going to get you into trouble. If there's any breach of patient safety or whatever you're doing or have done that could potentially have had a negative impact on patient safety. So that was very clear from CMS regional office, one of the ones I spoke to this week. So and that was not news to me. It's like, of course, you would want to do that. So I just wanted to mention that.
Yeah, and you know what, Lisa, that's such an important thing. It's all about patient safety. Compliance equals patient safety, period. And oftentimes we get so distracted by the reams, and I mean, there are thousands of pages of regulations, that we forget that at the bottom line, CMS is going to pull, or Joint Commission, either one of them, they're going to pull the trigger if they are not convinced that your processes are safe. And so, to me, when I'm trying to go into a client and have them think of, they're not going to be experts in the regulations. That's where we come in. But what they should be expert in is what they're doing to keep patients safe. And if they can demonstrate that to themselves, they should be able to demonstrate that to the surveyors. But bottom line, as you suggest, that's the ultimate test, always. During the pandemic, after the pandemic, before the pandemic, have you been keeping patients safe?
Right. That was the takeaway I had, and that's what, as you mentioned, that's what we always try and tell clients is bottom line. It's patient safety that's what's going to drop the hammer in any case. Documentation issues, other things can get you a standard out or whatever, but the safety of the patient is what we're all concerned about. But I don't have anything else I particularly choose to talk about. Is there anything else you'd like to conclude with?
Well, no, Lisa, I think it's a good discussion. I think we might have further discussions. I just want to remind everybody that this is part of a series of podcasts that we're doing and blog posts. And right now, of course, they're all focused on, pretty much all of them are focused on the COVID-19 issue. But these podcasts are going to be an ongoing feature of Greeley services to our clients and to the healthcare community at large. And so we encourage you to stay in touch with Greeley.com for blog posts, podcasts, videocasts, webinars that are available to you, our clients and our colleagues across the country. And Lisa, I just also want to join you in commending the people who are out there every day on the front lines during this time. I know we're getting used to hearing that from everybody, but I think it can't go without saying. We need to say it, that it's a special kind of person who goes into healthcare, and the people who go into healthcare are dedicated to patients. And that there is nothing more evident than when a person walks in to a building filled with individuals with a potentially deadly illness, and what they're really concentrated on is taking care of that patient. That's a special kind of person, and that's why I'm really proud to be associated with you, Lisa, with your colleagues from the clinical setting, and for our clients out there who do that not only during pandemic, but they do it day in and day out. I'm proud to be part of this industry.
I am too, but I also want to give a shout out, if you will, to not just, I mean, I'm a nurse, so of course I'm going to be all, very thankful for my colleagues. But I also want to mention the environmental services workers, the physical plant workers that had no way in their wildest dreams think that they would be involved in something like this, yet they go in and day out. They leave their kids, they come back. I mean, it's one of those things where it just shows the fortitude of the whole healthcare system when we have everybody working as a team. So I echo that.
Yeah, Lisa, thanks. It's really great, and just be safe out there, everybody, and subscribe to our podcast. We hope you like it. Let us know if there's some topics you want us to cover.